Hello, good evening everyone. This is Dr. Siddharth, third year orthopedic resident, and today we will talk about deep vein thrombosis. It is an important topic from examination point of view. So, we will divide this topic in two parts, part 1 and part 2. Part 1 will constitute the fundamentals understanding of this process, as it is critical to comprehend the mechanism of action of the therapeutic anticoagulants used for DVT. We will talk about the primary hemostasis, the secondary hemostasis, virtuous triad. We will talk about the platelet aggregation pathway. We will talk about the extrinsics and the extrinsics pathways in the coagulation cascade. We will look about different factors. We will look about plasminogen activation and how do clot degrade. We will talk about different antifibrinolytic agents, and further at last we will talk about antiplatelets, anticoagulants and profibrinolytics drugs. We will basically cover the fundamental of this topic. Along with it, we will cover the risk factors, the complications, pulmonary embolism, deep vein thrombosis, fat embolism in the second part. Coming straight to our topic, let's talk about hemostasis. Hemostasis is a dynamic process, we all know, constantly balancing clot formation. Balances clot formation and dissolution. Any disturbance in hemostasis, which can be due to endothelial injury, stasis, or hypercoagulable state, can lead to disturbance in this virtuous triad. This disturbance can cause disturbance in the hemostasis, and this disturbance can lead to activation of primary pathways and secondary pathways. The primary hemostasis constitute vasoconstriction and the platelet activation, which leads to platelet plug formation, and secondary hemostasis constitute the coagulation cascade, which produces thrombin and which leads to conversion of fibrinogen to fibrin. This fibrin, along with the platelet plug, causes blood clot stabilization. This blood clot formation can be degraded by the body by release of plasmin, which causes fibrinolysis and clot degradation after the coagulation has been achieved and body is back to hemostasis. So let's look upon it one by one. The vasoconstriction. Vasoconstriction is achieved by basically three mediators: the neurogenic mediator, the myogenic mediator, and the endothelin mediators. These three mediators is released in the blood vessels by the subendothelial and the endothelial membrane, and this causes temporary vasoconstriction at the injury site. This vasoconstriction at the injury site leads to decrease in the blood flow, which causes a temporary hemostasis and more number of activators and platelets to aggregate at that area. Along with it, platelet activation pathway starts. Let's look upon platelet activation and how does it help to get a platelet plug. Platelet activation is basically divided into three parts: the adhesion, activation and aggregation. The adhesion, so suppose this is our blood lumen with the subendothelium and the endothelium. There is an injury which we can see the endothelium has been disrupted and the blood has been exposed to the subendothelium. The platelet which moves in the blood gets adhered to the exposed subendothelium tissue by a variety of mechanisms. In this case, this is our platelet, and the receptors which we will focus on is the GP1B and the alpha 2 beta 1. This GP1B attaches to von Willebrand factor, and the alpha 2 beta 1 attaches to the collagen which is present inside the subendothelium. This collagen helps to adhere the platelet along with it with the receptor alpha 2 beta 1, and GP1B attaches to von Willebrand factor. This is a cofactor which helps to adhere the platelet to the subendothelium. After this, the platelet changes its shape into a stellate shape. We can see this shape has been changed and the platelet has been activated. So our process had started from adhesion to activation. Once this activation starts, the platelets start releasing few mediators like serotonin, ADP, and TXA. TXA stands for thromboxane. These mediators are important as we will look ahead in our video that different drugs and different chemicals which inhibit this pathway leads to anti-platelet activity. So basically just remember these three names as of now: serotonin, ADP, and TXA, thromboxane. This leads to activation of the platelet. Further, this activation of the platelet causes alpha 2b and beta 3 receptors to attach with the fibrinogen. This fibrinogen is present in the blood and causes platelet to get adhered to itself with the help of ADP. ADP acts as a mediator which gives a positive feedback and leads to more number of aggregation of this platelet. So our platelet like this gets attached to the site of injury and leads to platelet plug formation. This platelet plug formation now needs to get transformed into a blood clot, which will be supported side by side by our secondary hemostasis process. We have studied the primary process where vasoconstriction helped, then platelet activation with the help of von Willebrand factor and the fibrinogen. We have seen how von Willebrand factor helped the platelet to get adhered and to get activated into a stellate shaped and then release the serotonin, ADP, and thromboxane, which itself stimulates more number of activation of the platelets, which later with the help of ADPs helps to get aggregation with each other with the help of fibrinogen. So after this step, we will now look upon the coagulation cascade, which helps to stabilize this blood clot. And the stabilization of this blood clot is done by the coagulation cascade, the intrinsic pathway, the extrinsic pathway. We have learned about different factors from 1 to 12. In the intrinsic pathway, the factors start from factor 12, which gets transformed to factor 12a, which is the activated factor, which helps further 11 to convert into 11a. 11a factor transform 9 into 9a, and 9a basically further leads to activation of factor 10 to 10a. This factor 10a is a factor common in both the pathways, the intrinsic and the extrinsic pathway. As in the extrinsic pathway, any vascular endothelial injury causes tissue factor, which is factor 3, to activate. Along with it, factor 7a complex also get activated. This tissue factor 3 and 7a activates the factor 10 to 10a. Along with it, factor 5a acts as a cofactor which combinedly activates factor 2, which is prothrombin, into thrombin. Here we have seen the tissue factor which activates the factor 10a also activates factor 11a. So this both the pathways are interlinked to each other, the extrinsic and the intrinsic pathway. In this case, after the activation of prothrombin into thrombin, which is 2a, this thrombin, which now will act as a positive feedback. Positive feedback means it will itself hit different chains in this pathway and cause activation of every other reaction. Basically, this thrombin will activate its own production, leading to production of thrombin in the blood vessels. This thrombin, with the help of factor 13, which is stabilizing factor, causes fibrinogen, which is factor 1, to convert into fibrin, and fibrin is a monomer. Fibrin is a monomer which causes cross-linked, and fibrin is a monomer which forms cross-linked fibrin, leading to a platelet clot formation. Here we have seen how coagulation cascade had led to production of thrombin, and thrombin itself causes positive feedback mechanism in the coagulation cascade and also leads to conversion of fibrinogen to fibrin, and this fibrin gets cross-linked and leads to platelet plug stabilization and forming a blood clot. So up till now we have learned about our primary hemostasis, vasoconstriction, which is done by the neurogenic, myogenic, and the endothelin. causes the vessels to contract at the injury site, leading to decrease in the blood flow. Later, this is also reinforced by platelet activation. Platelet activation is activated by different mediators like von Willebrand factor, fibrinogen, and ADPs. Also, we have to remember about serotonin and thromboxane. There are receptors which help the platelet to adhere to the collagen present in the subendothelium, like alpha 2 beta 1 and GP1B, which helps to attach von Willebrand factor to the platelet, leading to change in the shape of the platelet and activation of the platelet. This activation of the platelet causes release of ADPs, and ADP further stimulate the platelet to get attached to each other with the help of fibrinogen. Along these all pathway go side by side along with the coagulation cascade, where intrinsic and extrinsic pathway go hand in hand. The extrinsic pathway, due to the vascular endothelial injury, causes the release of the tissue factor 3, which gets activated into factor 3A, along with factor 7A gets into the common pathway and activates the factor 10A. This tissue factor and 7A also activates factor 11 into 11A, which further activates the extrinsic pathways, and the extrinsic pathway leading to factor 10A, along with its cofactor factor 5A, leads to activation of prothrombin 2 into thrombin 2A. This thrombin acts as a positive feedback mechanism into the main circuit and activates every other reaction. This thrombin, which later activates fibrinogen factor 1 into fibrin monomer and causing the cross-linked fibrin products, which leads to clot formation at the desired injury site. This cross-linked fibrin helps to stabilize the platelet clog. So once the clot is formed and haemostasis is achieved, the body tries to dissolve the clot. The clot dissolution is happening by fibrinolysis. This pathway is mediated by plasminogen. The plasminogen is a molecule inside the vessels which remains inactive in its normal form. When there is demand of degradation of the clot, the endothelium releases tissue plasminogen activator. This tissue plasminogen activator removes the inactive molecule from the plasminogen and activating the plasmin. This plasmin causes degradation of our fibrin products, and these fibrin products get removed from the clot, leading to release of D dimer and fibrin degradation product. And this D dimer can be used as a laboratory measure to look for fibrinolytic status. The tissue plasminogen activator like streptokinase and urokinase we all know. Here we will see a gist of what we have just talked. The plasminogen, which causes the conversion into plasmin after activation by urokinase or streptokinase, leads to conversion of fibrinogen to fibrinogen degradation products along with D-dimer. This plasminogen conversion into plasmin can be inhibited by antifibrinolytic agents. So this antifibrinolytic agent like tranexamic acid doesn't let plasminogen to convert into plasmin, and so the clot which is already there doesn't dissolve, which leads to decrease in blood loss, leading to better haemostasis if needed intra-op. So now we will look upon the antiplatelet, anticoagulant and profibrinolytic pathways. The endothelium, in this endothelium, in case of platelet, releases nitrous oxide. Also prostacyclin. These two hormone leads to anti-platelet effect. That means the platelet which were formed and activated repel each other leads to decrease in aggregation, and decreased aggregation causes decreased platelet plug formation. Also, in the anticoagulant pathway, there is a molecule known as heparin sulfate. This heparin sulfate, we'll talk here, is a structure which gets attached to antithrombin. What is antithrombin? We will look ahead in just a few minutes. And the antithrombin attachment to the heparin sulfate leads to suppression of factor 10 and factor 2A. So that means that this molecule as a whole inhibits factor 10 and thrombin. So coming to our coagulation cascade, the thrombin and factor 10A is inhibited by heparin sulfate along with antithrombin. And if these two factors get inactivated, our most of the pathway leading to the production of fibrin and clot gets inhibited. So we have to keep in mind that this heparin sulfate is a molecule which leads to inactivation of factor 10 and factor 2A. Now, this TM is thrombomodulin. What does this do? What does this do? Thrombomodulin causes thrombomodulin is a molecule which causes attraction towards the thrombin. The thrombin which gets attached to thrombomodulin leads to attraction of another protein called protein C. This protein C causes anti-factor 5 effect, and this anti-factor 5 and anti-factor 8 effect leads to inhibition of the coagulation cascade, which we talked earlier. Along with protein C, there is a cofactor protein S which also helps sometimes to inhibit the factors mentioned. So basically this is all we need to know in this chapter. The last to keep in mind is the profibrinolytic pathway. This pathway leads to the dissolution of the fibrin clots, as we have discussed earlier, with the help of streptokinase or urokinase, which later leads to in activation of the plasmin, and so the activation of plasmin causes the fibrinogen to convert into the fibrinogen degradation products, and so the hemostasis is maintained in our body. So this was all about this video, and in the next part 2 we will talk about different drugs and their mode of actions in this pathway, so that we can understand the dosage and their uses in our different orthopedic practice. Thank you.